Good evening, all. Depending upon your time frame, greetings from StudyMRCEM. As you're aware, you're all going to gear up for the OSCE exam, few in the month of July, and maybe few in the month of November, October, depending upon the slot availability. What will be my primary responsibility here? I'll be just going through some of the mock OSCE stations, and I have got some 4 or 5 OSCEs, so that we have identified few students who have shown us willingness to run through this OSCE. And I also give you an overview of a program that is going to happen in the month of July in Cochin. So that is actually our live circuit program. We have actually scheduled a live circuit program for the July diet, those who are planning to attend the exam in the month of July 23. So prior to that, we have planned for a live circuit program. So I'll just give you a quick overview of what is exactly going to happen. So those who are interested can join for that also. So myself, Dr. Sreekrishnan, I'll be dealing with these sessions today. So without further delay, so as our presentation start, we always start with a quote of the day. So success, it will just not come with one step. So it has got a lot of things to be done. You have to work, you have to improve yourself. You should have a clear focus, you should have a passion, and you should push for it. And you should have a great ideas, then only with the proper persisting things, then only you will have a success. So it's a very difficult thing. But when you have a proper mentors and a team like StudyMEDIC, where we are there to help you, you can achieve this without much issues. So coming to OSCE. So OSCE, as you know, it's basically, OSCE is all about this pie chart. That's what I will say to you. So once you read this pie chart clearly and your instructions clearly, you are done with the OSCE. Even if you don't know anything about the station, you know the pie chart and which area you need to concentrate on, and you introduction and closing remarks. That is what is needed for all the stations. So if you can do an introduction and a closing remarks, and even if you don't know about the station also, you might be able to go through that station. So it's all about practice. It's all about proper practice, and you should know this pie chart. So that is why I have put that is in the first level. So know the pie chart. So what is exactly being asked for? Suppose you take this pie chart here. See, the history taking is the priority. If you're concentrating on something else rather than on history taking, then you're losing on the station. So that is a priority. So always understand that the pie chart is the key for your success in the OSCE. Understanding the pie chart and managing the time accordingly to the pie chart. So that is a key thing one I wanted to let you know. Then always there are certain domains tested. So domains tested will be clinical reasoning, decision making, communication skill, including conflict with your colleagues, history taking and information gathering, clinical examination skills, practical and certain pinnacle skills that you need to gather, then teaching skills, and organization and prioritization. So see, an emergency physician, I will say, is a manager. So he's a manager in the sense he's managing the patient, as well as he has a lot of administrative duties also. So when you have the early phase of your career in emergency medicine, you will be more concentrating on patient care. But as the grade increases, like you are becoming a specialist, consultant, like that it goes up, your administrative responsibility increases. So an organization skill and prioritization skill is very important for an emergency physician. Like not like in any other specialty, but when at present, when you're looking at me, my 50% of the time I'm devoting for the patient and 50% will be my administrative aspect. So that is how you need to understand. So these are the certain domains that will be tested for your OSCE station. And these are the domains. This is straight from the Royal College of Emergency Medicine site. So how the OSCE marking is being made? RCM OSCE examination follow a domain-based marking scheme, and domain-based marking scheme is a style of assessment in which each candidate will be assessed against a series of domains. The domains are skills which candidates are expected to demonstrate within each station. So that is the same thing what we have discussed in the previous slide. In each OSCE station, then this is very important, not one domain, maybe 1 to 4 domains will be tested. So that is the pie chart. Each domain will be separately weighed in relation to its overall importance within the station. So support one station, you have got just communication skill, the concentration will be on just on the concentration skill. The candidate will be assessed by the examiner who will form a judgment on the level of competency they display in each of the station. A domain per skill ranging from below minimum level of competence to well above for each competence will be marked. So this is the again a nutshell. You can have well below, and this end you can have task completed to high standard. So this is again how they will mark you from 0 to 4. So this is depending upon how well you perform in that station. So the examiner judges judgments of the candidate performance for each domain within the station will be converted into a numerical value based on the weighting of the domain. Suppose I have been given 10 marks to a station completely. Suppose I'm telling 70% of the time, 70% of the mark is for the OSCE. So 7 marks is for your history examination. It will be for your history taking. So out of this 10, the 7 marks will be for your history taking, and the rest 3 will be your communication skills and overall. So that is how the marking pattern is going to happen. And so again, you will get 1 minute to read the each station, and you will have total of 8 minutes for station that you will be able to get, and total of 160 marks you will be able to score. So this is again how they usually do this with your SLOs. Now we have completed our domains. Now, depending upon this specialty learning outcomes, each station will be marked. Suppose you will start with a complex stable patient, then you have history taking, answering the question, then you have resuscitation station, then you have a trauma, then you have pediatric emergency, procedural skills, complex challenging situations, supervise and teach. So this may be the role number 1 who's going to will go through this order, but if you are role number 4 or 5, you'll be starting in between, or sometimes you might be starting from the rest station also. So from each of these, they are planning to cover certain SLOs. So SLOs 1 to 9 will be covered. So each examiners will have a global score. That's what I have told you. And passing at least one of the 2 resuscitation is mandatory now. So you cannot, if you're don't good at resuscitation, don't attempt for OSCE. So one advice that I need to tell you that wherever you are, whichever country you are, you do the properly the resuscitation algorithms, understand the resuscitation algorithm, the European resuscitation algorithms. You have to be thorough with those algorithms. No matter how good you are in the session, if you don't clear at least one session, you will be failed. So that's the sad part of it. Now, let's start with the mock OSCE. So I have given you an overview of what we are going to do. So I have got a list of people who have shown their willingness. So I'll start off with the first candidate. So Dr. Vail, you're here?
Yes, I'm here.
Yeah. So shall we go with the first one for you?
Okay.
Yeah. So I'll give you a short history. So I'll just note down the time for you. You will have 1 minute for reading the scenario, and you have 8 minutes. So you can ask me the questions. I'll be able to guide you in it. Ready?
Okay.
Yeah. I'll just take my timer. Okay. So this is your scenario, Dr. Vail. I'll read it out for you. Dr. Liz is a newly qualified doctor on the gastroenterology ward. Okay. She has attended ED at 3 a.m. You were on duty after a needle stick injury from a ward patient. She is very tearful and anxious at what needs to happen next. You are asked to talk to her and about discuss what needs to be done next. So that is your target. So basically, this is a very common practice in ED. Some doctor is coming to you in between in the middle of the night with a needle stick injury, and you have been asked to discuss with her regarding what to be done next. Is it clear?
Okay, clear.
Yeah. So I'll get you the pie chart. So this is the pie chart.
You know, my first training. So
I can't hear you, Dr. Vail. Can you be a little bit loud?
That's my first time.
No issues, no issues. This is
Uh,
always being, that's always good. No, you're doing it right now rather than doing it, for your OSCE station.
uh,
So
okay.
this is your pie chart.
Good
So
evening.
I'm not very, I am not looking into the time aspects right now. Okay. So just see
Okay.
this. This is the history taking,
Test taking.
communication skill, and reasoning. So it's basically these things are clubbed together. So you have to balance it yourself, and you can start. So I am the doctor who has been sitting in front of you. So I'm ready. You can start.
Hi. What
Hi.
happened? My name is Wael.
Okay.
ER registered. Uh, how are you doing, Tori?
Uh,
Tell me what happened.
See, doctor, I was there in the ward, and I had gotten needle stick injury here. And since last week, my friend told that she got hepatitis B following needle stick injury. I'm pretty worried. So that's why I came running to the ED right now.
Don't worry. We will take care of you.
Thank you.
Can I ask about your vaccination history? Did you have vaccine before? Your title measure?
What vaccination? In childhood, I have taken some vaccination. After
Hepatitis
that,
B vaccinations, B doses.
hepatitis B vaccination. See, when I joining for the employment, they told me to get done some vaccination, and they said that my titer everything is fine, and I
How
just
many
need to
shots you
go to
have?
work. Which one?
How many shots you have from this vaccination?
I don't
Really?
remember exactly.
Okay. And what happened after that? Did you wash the wound? Did you clean it? What happened after that? Did you squeeze?
Yeah, yeah. See, actually, no, I was there in the ward, and suddenly the nurse called me that they are not getting an IV line for a patient. So that I went in, I didn't wear a gloves properly, actually. And I
Okay.
just went ahead and was putting a cannula. And after that, the cannula, the sharp was there. So I didn't notice it, and it got pricked into my left index finger.
Okay, don't worry. Do
I
you have
thoroughly
any
washed it with
comorbidities?
water, soap and water.
Okay. Okay, do you have any comorbidities like blood pressure, blood sugar,
I don't have any.
and something like that? Okay, don't worry. We'll take you to the examination room now, and we have
Yeah.
going to collect the blood from you, and we will have content
Why
for
you
the
want to
patient
take
and
blood from me?
for database for basic level, and we will repeat again if needed. I will check the all virology. I will check hepatitis B titer if you have vaccine before or not, and we will give you shots now for
No, no, I am not ready for any
immunization.
injections right now. They told me everything is fine for me.
Okay. No, see, there is risk. There is risk for transmitting diseases by needle injury. Uh, the biggest risk for hepatitis B, even HIV, even
No,
pregnancy is less.
that patient, everything is negative. Why you wanted to take blood from me then? That patient, they told me everything is negative. All he's not hepatitis B or HCV or hepatitis B positive. But I was worried. I just worried. That's why I came to the ED.
I think I failed.
Uh-huh.
I think I failed already.
No, 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 no. That's okay. So see, you have almost ticked all the boxes. I'm not saying you've done very pretty badly for the first timer. It was pretty good because such stations will come. See, what is in OSCE? The thing is that we cannot predict or we cannot judge what the instructions they have given to the actors. Okay. So we have only what we have is we have got some 125 MRCEM OSCE book, and there are a few videos where we are seeing these are the situation. So the situation, what instruction that doctor has given, that examiner has given to the patient, we don't know. So we need to act smartly depending upon the situation, whatever is being given to you.
Okay.
So these are certain stations that very commonly are stationed. So one important thing that you have done is that you have introduced, we'll just start with the debriefing first, Dr. Whale. So whatever you have, I will go ahead with the positives, whatever you have done first. Okay. So you have introduced self. That is one thing that you have done. But That is fine. Then you have comforted the patient appropriately. You have said, don't worry, we will take care of you. That was good. So you definitely ask whether the wound has been washed thoroughly or not. So that is a very good question, which is a very relevant thing that you have asked. Yes. How the his injury happened, you have asked. And one more thing that would have been better is since how long the injury has happened. That is again
Okay.
very specific. That again I am giving you to the history just soon after this has happened. But when you are not, when the doctor is, I have been a smart doctor, I have given you the answers for that. But if the doctor is not saying, or it can be a staff nurse, you need to ask what is the exact time of injury. That is one thing that you can add on. And these are the things that you have done. And one most important thing what we missed, now we'll just go into missing things. You never confirm the identity that I am doctor. Please. It can be someone else. So always make a practice that even if somebody is telling that this is this doctor, you always have a practice of confirming the patient's identity. Whether it is a bystander, whether it is a breaking bad news station, whatever be it, you make sure that as a common practice, you confirm the identity and you go ahead with the asking about the sequence of events, which you have done. And next most important thing here, it is a donor status. You have asked for the status of the patient, that is the doctor who has come with the needle stick injury. But you never asked what is the status of the patient. Then only your decision will come. Okay. So if the patient is already hepatitis B positive, then your treatment plan completely changes. Hepatitis C, hepatitis HIV positive, then automatically our plan of action changes. But the patient is already tested negative, then it is a different source. But what most commonly will happen is that there will not be any testing done previously for the patient. Sometimes the patient is coming for something else, why we should check a pre-op serology. If that is not checked, you have to make sure that we have to do these things. You have to check blood from the patient. Then you have to discuss that I am very anxious that whether I need a PEP or not. So then you need to convince me that if the patient is negative and you have got this, and if your titers are good, you doesn't need PEP, post-exposure prophylaxis. But if the patient is positive, you are not vaccinated, then you need PEP. So that post-exposure prophylaxis part you need to discuss well in this. That is your basically your reasoning skills that you need to utilize here. So when you see this, you have taken the history, you have done doing a communication. This part is a whole chunk of reasoning. So reasoning is what is the source patient, whether the patient's blood has been taken, whether PEP is required or not. That is very important. And definitely she needs a follow-up because it's a busy ED. You cannot take care of her right now. Maybe you're sending an investigation, they will be coming after some time. So follow up in the occupational health clinic. So whatever be the employees OPD or whatever be, you name it, you need to have a follow-up for that. And since these are all hypothetical situation, okay, if I'm very anxious, I'm hyperventilating in the ED, I cannot go back to work because I'm a doctor. I want to go to the ward for the work again, because if I am hyperventilating, I cannot go back to work. So you can tell her that you can discuss with the same with the seniors so that you can take and shift off. So those things all depends upon how the scenario comes in. It is not true for all the stations, but maybe the patient is very much anxious that you think that it is not, it is risky for her to go back to the duty, then at that moment you have to take that call. So that part is very, very important. So you need to sometimes escalate this thing to his senior on duty and make sure that someone else is covering her for on duty during that time. And most importantly, every hospital, see, not this hospital, everywhere, wherever you practice, there is something called as an incident form. So this sequence of events, whatever has happened, we need to document it's an incident form, and they need to get certified by their superior, by their supervisor. This is reasoning is basically why we need to have an audit of needle stick injury. What is the turnaround of positive that is happening from needle stick injury? And also we need to prevent this first. Suppose you are having an audit only, then you know that I am saying it very clearly that I didn't wear gloves. So I have been not been given a proper training. So that is the reason why a needle stick injury has happened. For that reason, you should raise an incident form and you should be very calm while that always you have done that well. And finally, always keep mind in you when you're doing an OSCE. When you're closing an OSCE station, always have a practice that you have any final questions that I will be happy to answer. So this, you make it as a practice. When you're doing this OSCE introduction, confirming the identity. And one more thing I will tell, if it is a female or someone else that is in distress, you can ask for some assistance. You want someone else to be with you. So that is some clues that will work for any stations. And later on, while you're concluding, you can thank the patient, and you can, before that, you just ask, you have any more final question that you want me to answer. So that is in a way that you can close this session. Is that clear for you, Dr. Will?
Yes, very, very clear.
Yeah. So just do this practice. See, whatever situation arises, you have to be smart during that OSCE session. But in a general way, you have to have an introduction. In between, you will have a major discussion time. Then at the last, you will have a conclusion remarks. So you plan it this way, you will not have any problem in any of this OSCE session. Okay.
Yes.
Fine. Yeah. So we will go to the next. So who is that lucky fellow for the next is Dr. Shivaranjit. Is he here?
Yes, sir. Good evening, sir.
Yeah. Good evening, Shiv. So Shiv, we have got a scenario for you, and
Yes, sir.
I have gotten. Sorry for that. I have gotten real patient bystander. It's not a real, it's a mock patient bystander for you. So is Soumya around? Are you able to hear Soumya?
Yes, sir.
Okay.
Yes.
So the communication, so I'll be just the examiner. I'll be just observing, Shiv, what you're doing, what questions you're asking. I'll be just observing, and your communication is with Soumya. Is that clear?
Okay, sir.
Okay. So I'll give you the scenario now. So station 2, you have been dealing with case of Mr. Ashok, who is a 66-year-old man. He was found collapsed on the pavement while walking to work and arrived in ED by an ambulance with a GCS score of 5/15. He is intubated and ventilated and has returned from the CT scanner. His CT has been reviewed by the neurosurgical consultant, who said he will not survive from his IC bleed and he should be made comfortable. His wife has just arrived alone. Explain the situation to Mrs. Ashok. So Mrs. Ashok is Soumya for you. So you can just go through the scenario once again. You have another 30 more seconds. If you're clear, then I will show you the pie chart.
Okay, sir.
Yeah, pie chart is very clear. It's all communication skills. So only one domain is tested here. This one station is definitely going to come in your OSCE. So breaking bad news station, 100% sure. So what will be the breaking, whether to withdrawal of support, whether to tell that he's going to die, all those things doesn't we cannot say, but definitely one breaking bad news station is going to happen. So this is the image. So if you're ready, you can start communicating with Mrs. Ashok.
May I just know the name of the patient?
Ashok.
Okay, sir. I'm ready.
Yeah. So we are ready.
Yes, sir.
Yeah, you can start communicating.
Hello. Hello, ma'am. May I know your name, ma'am?
My name is Rema.
Okay. Hi, Mr. Rema. In what way you're related to Mr. Ashok?
He's my husband.
He's my husband.
Hello.
Okay. What information has been transmitted to you till now? Do you have any idea?
He's okay, right? He has been admitted to hospital. I just came to know
Okay.
now. He's
Okay.
okay, right? Can I meet him?
Yeah, 1 minute. We just need to talk for a few minutes before meeting him. I'll just make sure that you meet him definitely. But few questions I want to ask you. Is that fine?
Yes, doctor.
You are comfortable or you want a chaperone nearby?
No, doctor. Just talk.
Okay.
Is he
Please sit
fine,
down.
doctor? Hello?
Yeah.
Is he-
Yeah. I'll just tell you, ma'am. The thing is that
Yes.
we have received Ashok in our hospital with the history that he has collapsed on the road. Okay. So when he came, his GCS was found to be, his conscious level was low. His sensorium was bad. Okay. So we
Okay.
decided to put the patient on a ventilator since his GCS is bad. Post intubation, we have shifted him for this CT scan.
Okay.
Post scan, we have seen the CT and he has got a big bleeding inside the brain. And following which, we have consulted a neurosurgeon also. And following which, the neurosurgeon has said few things. Are you able to follow till now, ma'am? Are you okay
Yes,
with
sir,
the
but he
committee?
was completely okay. He was
Okay.
completely okay, sir. So what happened to him?
No, apparently he was in the roadway and he has collapsed on the road. Following which, he was brought here. We suspected he could have a stroke. So his sensorium was low. We put the patient on ventilator. So after doing the scans, we found that he was having a big bleed in the brain, which I can show you in the CT. Are you able to appreciate this is his CT. Are you able to see this white thing which you see here is the bleeding, and this is the normal brain part. Are you able to appreciate that, the bleeding part?
Sir, but he was completely okay. There was no such signs.
Yeah.
He was
Previously,
healthy and fit.
yeah. Does he have any BP or sugar or any
No,
heart
no,
problem
no, doctor.
previously?
No,
Okay.
doctor. He just complained of a mild headache few days back,
Okay.
but nothing else.
Okay.
He's completely healthy and fit.
Okay. Okay. The thing was that his BP was high.
Is he
And
fine now, doctor? Can I meet him? Is he fine now?
see, regarding the neurosurgical patient, we have consulted with the neurosurgeons also. They tell that the patient is having a poor prognosis. We cannot tell the patient is good, but the patient will have a poor course in the hospital because he's having a massive bleed and the chance of
Yes. Will he
survival
get better after the treatment, doctor?
that we have to admit him. We have to give edema anti-epileptics, that is to prevent seizure or prevent edema. We have to give medicines for that, and we have to put him on long-term ventilators, and we have to see, and we have the chances are very less, but we can hope that he survives, but the chances are very less, madam.
No, doctor. I just can't believe because he was completely healthy and fit this morning.
Yeah, I do understand, but his BP was high and he has bled out in the brain, and because of that his sense has gone down. Do you have any doubts regarding that, regarding the patient?
No, doctor. He was completely healthy and fit. So I'm just shocked. So can I just meet him? Will he get better
Yeah,
after treatment?
we hope he gets better, but do you need any help? You want me to inform any of your family members, or do you need any support?
No, doctor. I don't have any family members at present nearby me.
Okay.
I just have
Do you
few
need any
friends.
social help? Do you need any social help?
No, doctor. I just want to know, will he get better after the treatment?
Uh, the chances are very less, ma'am, to be open with you, but we just give the treatment what he requires, then we'll see how he goes about. The chances which neurosurgeons are telling is that very less depending upon the CT and other things, but let's hope he survives. But the chances are very less. I'm very sorry to say this, ma'am. Is there anything, any doubts you have, or is there anything which I could do for you?
Okay, could you
If you
just
want to meet,
explain his reports, doctor? What went wrong with him? Because he was completely okay.
yeah, he was having a high BP, and
I did.
because of that,
He was
he has
trauma for such,
yeah, because of that high BP, he has some bleeding in the brain, following which he became unconscious, and the system that is involved in the conscious level has been affected, so that he was not responding. So to prevent aspiration and complication, we have put him on ventilator, and post which we have put a CT done, and his CT is looking very bad, and the chance of survival looks less. I'm very sorry to say this, ma'am. Do you need any help? If you want to see the patient, I can arrange, and I can.
Yes, yes.
Is there anything else which I could do for you?
No, doctor. I just want to know if he would get better.
Yes, ma'am. We hope that he gets better, but the chances are very less. Yes. I'll make the neurosurgeon also talk to you for the second opinion.
Yes.
Then we'll see what to do next. Is that fine with you?
Yes,
Any other
doctor.
required?
Yes, doctor. I would like to meet the neurosurgeon also.
Sure, I'll just contact them and make sure that he speaks with you also. Thank you.
Okay.
You can see the patient.
Okay. Thank you, Soumya, for that session. Shiv, we have done reasonably well. I'll say reasonably well. Why? Because there are a lot of areas where we are not trained in our undergraduate days. Actually, for breaking bad news, we hardly get any training for these things. So only once we plan for appear for these sorts of exam, we start, okay, there is a way like this where we can explain. For that reason, we have done extremely well. But there are certain points that you have covered almost everything, but there are certain things that we need to add on to the scenario when you have been given. Suppose the first positives we can ask is that you have definitely asked if you need any support confirming the patient's identity. I don't think you introduced yourself. Did you say that you introduced to the patient bystander? I don't think so. I didn't
No, sir.
hear. Yeah, I didn't get that because there was some network issues in between. I couldn't hear that part. So that's what I was just reconfirming. So that introduction part is very important. And anyone else needed, wonderful. You have asked for it. And you have always had that sympathy. And you were, throughout your conversation, you were having those important emotions. That was very good. One more thing, what we need to do is that you can ask her what exactly information what she has got till you started the conversation. So before you have the patient bystander sitting in front of you, you can just ask her what information she has got. I don't know whether you have asked because that couple of minutes I had lost my connectivity. So my voice was not clear. So that clarification part you need to do, clarify what exactly you know. So she might say that I was just got a call that he's not well, so I just came into the hospital to see him. So that clarification, what she knows is very crucial to build up the conversation. This is not for this, for any station, because suppose you have explained everything to the one bystander and the next time someone else is going to come and you are going to start from the beginning. So you have to be very clear for what exactly that bystander or the attender knows about that patient's. You have to ask that. So that is very important. One thing that we need to ask. You have explained the event. You have said that he was not well. You have put him on a ventilator. Why you have put him on a ventilator? And you have said what is the neurosurgery opinion. And one thing that I didn't want to say is you have given her some hope, which you should not have done. And you should be clearly stating that he is going to die. So that part you have to be very, 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 very clear. So you said that you are going to hope that he will improve. But if you give that hope, then the conversation is not going to happen what we are expected to. So that hope part you should avoid when you're having such a scenario, because I have told that he's not going to survive. So he's going to die is the key information. So that death word has to be told while during your conversation. So he's going to die.
Okay.
That word has to be said during the conversation. That is very important. And also make sure a habit that you offer to show her the investigation report and explain a little bit about the CT scan. That might help them to understand it better. So that is another additional thing that you can have an add-on, and you can use in between some silence. So for Breaking Bad News Station, you have to be a very good actor also. So you have to have you use a little bit of silence, maybe a couple of seconds or 30 seconds of silence where you are just allowing her to understand the situation, what exactly has gone wrong, because suddenly she is knowing that his husband is going to die. So that is one major information. After that, you give some 30 seconds of silence. So that will help her. Then ask if why would want to see anyone that you have done. Then you can ask for some religious belief. So if they have got something like they want to offer some prayer because he's going to die, that depending upon any religious belief. And one key thing, that organ donation. So discussion of organ donation. So in India, it is pretty difficult. So you can put forward a question like this. have your husband has ever told anything regarding organ donation to you before? Rather than are you willing for organ donation, you can ask something like this. Did your husband and you have ever discussed regarding organ donation? If she says yes, then you can go ahead with the conversation taking to the transplant coordinator. So that organ donation part is one thing which is very key that you need to add on. And the legality getting involved, because maybe the coroner needed to get involved into this. So that part you need to clarify. So these are some key things, one or two things that you have missed, but rest you have done pretty well. You have asked that you, if somebody wanted to call her again, that you have done, and like to see the patient, that you have done. And one more thing, what I faced in my OSCE station is that they wanted me to ask the patient bystander to repeat whatever he has said. So that is one, suddenly the examiner told, why didn't you ask? Usually there will not be any conversation, but that you could have asked that bystander after the exam. I met him, so you could have asked the bystander to ask to brief you regarding the sequence of events, what has happened, and any questions that you have done. So if you give me, you will definitely pass this station, but you can do it better way by adding these additional points. Is that clear, Shiv?
Sure, sir. Sure, sir.
Yeah.
I was giving her hope. That was wrong. I do
Yeah,
understand. Sorry.
Yeah, that's the only thing. Giving hope, organ donation, these are the additional points that we could have added. So you could have scored maybe 10 out of 10. Otherwise, it will be a 6.57. That's the difference. Okay, fine. So
Thank you,
we
sir.
just, yeah, thank you, Shiv. Thank you, Shiv. And Soumya for that help. Now we have the next. Is Dr. Prince here?
Yes, sir.
Yeah. Are you ready, Prince?
Yes.
Yeah. I hope you would have seen the scenario because I had moved the cursor. So it's a 52-year-old patient. Mrs. Bedi has been diagnosed with a community acute pneumonia and is in septic shock. Despite fluid resuscitation, she is hypotensive, and you need to start an invasive blood pressure monitoring. So insert an arterial cannula into Mrs. Bedi's radial artery. A mannequin will be used. So basically, you have been asked for a practical skill demonstration. So see here again, this practical skill demonstration can be a teaching station with practical skill demonstration also. So they might ask you simultaneously, you teach couple of paramedics how to set up the arterial line. So meanwhile, you are doing the procedure, and after that, you are connecting these transducers and all those things. You need to teach the student. So it can be multiple domains. So practical skill learning with history, clinical examination, all these things together will come. Maybe 4 domains will be tested, but I am not giving you that here. I'm just giving you 2 things only. You have to have a good practical skill, and you have to have a good communication skill. So if it is okay for you, we can start right now.
Okay. Good evening. I'm Dr. Prince. Can you tell me confirm your name and age, please?
Yeah, I'm Mrs. Bedi. I am 65-year-old. I don't remember the
Okay.
age exactly.
Oh,
So whatever be it is,
okay.
65 years. Okay, fine.
Okay. I'm Dr. Prince. I'm the currently the one of the ER doctors.
Okay.
So I've been. Do you know what is happening right now to you actually?
No,
Where you
I have, the doctor said I have some infection. So that's why I'm being admitted here. And a few nurses, they are coming and pricking me since last a few hours. I don't know what is happening to me.
Okay, so I would like to tell that you have had a severe infection, and because of that, your BP has come down. So instead of pricking you continuously, we would like to put a arterial cannula, that is, insert one of the cannulas into your artery, so that we can continuously monitor your BP. Okay, and take a blood gas if required, any other bloods.
Okay.
So I want to tell you that the procedure will be completely pain-free, and that will be
No, I
using
cannot
local
do that because
anesthesia.
last time, since last 3-4 hours, they have been continuing. I'm having a lot of pain.
Yes, I'm sorry that you have pain actually. Would you like some painkillers right now for the
I would
pain?
like to get something because it's very painful for me.
Okay, I'll ask the sister to give you the painkiller right now. Meanwhile, while that is being done, I will just explain what I'm going to do.
Mhm.
Is that okay with you?
But okay, see, I have got some, you have given me of painkillers that also scares me. Why? Because I
Okay,
have got some allergies. So
okay, okay. So
that
can you
part you
tell
take
me
care.
like, okay, so can you tell me like whether you have had previous allergies, whether you are allergic to any medicines or previously?
No, like couple of years back, I had this bad tummy pain. So they gave some injection, and after that, I had a full rashes all over my body, and they said that I should avoid painkillers.
Okay, so maybe I can give a test dose to see whether there is any allergy and then give the full dose for your painkiller.
Okay,
Okay,
okay, that
and
sounds reasonable. Yeah.
okay, and we'll give you the painkiller. Meanwhile, for this also, for the local anesthesia also, we'll give a test dose so that we confirm that you're not allergic to it.
You're going to give
Is
me
that
anesthesia
okay?
for this procedure.
Yeah, I'll give a local anesthesia so that I'll numb the area where that I'm going to prick you.
Okay,
I'll be
okay,
pricking your left wrist, left artery actually, left
okay,
artery. So I'll be pricking, I'll be numbing that area before I actually prick it. So meanwhile give a test dose also so that I am sure that you are not allergic to the local anesthesia.
okay, okay,
Is that
fine.
okay?
Yeah, that's fine.
Okay. So I also want to confirm that the patient is in the resuscitation area connected to the monitors. And do I have any vitals or anything?
Uh, Now I am not Mrs. Bedi. I am Dr. Sreekrishnan. I just want to give you an information. She's in the ICU.
I see. Okay. 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 So, so I just wanted to tell you what I'm going to do. And I would like, so what I'm going to do is numb your left wrist and put a cannula into your radial artery. Meanwhile, I will check for the Allen's test also to see whether collaterals are present or not, so that she doesn't have any complications. And I have also told that the procedure will be pain-free because I will be giving a local anesthesia.
Okay,
And
okay, that's fine.
okay, and there are some complications which can happen, like there can be some collection, blood collection, or some infection also. But at present, you have very low risk of having any side effects at present. Okay, and
Okay,
if I am having any difficulty, I will inform my seniors or anesthesia if I'm having difficulty in getting the lines. Okay, and can you tell me like what I have told you again, like what you have understood from what I have told?
yeah, you said that you're going to put one line inside my left hand so that you
Okay.
said it will be pain-free. So that's what I
Yes.
understood.
Okay, and that cannula will be connected to the monitor, and we'll be able to get your BP continuously. And if any
Mm.
blood tests are required, we can take through that also.
Okay.
Okay, and so I just want I want you to give me consent that you are okay with the procedure.
Yeah, I'm fine with the procedure. Yeah,
Okay. So meanwhile, during the procedure, if you have any difficulty, please tell me
sure, sure,
if you
sure.
are facing any difficulty.
Definitely,
Okay.
definitely. Yeah,
So um, so that's it, sir, actually.
that's it. Okay, Prince. It's a good try, but just see the pie chart. This is what we will do wrong in all
Practical skill,
stations.
I guess.
Practical skill is the majority and communication skill
Mhm.
is only the small thing. You just reversed it. That's only
Yes.
the wrong thing that what you have done. You have
Yeah.
taken your whole time for your communication skill, and but practical skill demonstration never
Yes.
happened.
Okay. Okay.
So that's what. But your that part everything is fine. But one more few things that you can initially itself you could have offered analgesia. That is always
Yes, I forgot
that is
actually.
one thing always we miss. That pain score is one of the fifth important vital signs. So keep that in mind always. So offer analgesia when and where it is needed. It is not for this patient alone. Anywhere if the patient is in pain, offer analgesia. That's a simple thing. Definitely ask for medication history. So I give you a clue that you have missed that
Oh,
history of
yes,
allergies.
yes.
So I gave you a
Yes.
clue by giving you something. So medication history. You need to explain the procedure, but not in a big detail that you are going to fail the procedure and call the senior. That all is not needed
Okay.
at all
Okay.
because the patient will
Okay.
lose confidence in you. Then if I would have been the patient, I would have said, then just call your senior and just put the line. I cannot take any risk. So that part better to avoid in such situation that not needed to be said discussed in an OSCE station. Then consent, you went through the consent site you have mentioned, you are going through the left radial artery. You said regarding the alliance test to the patient bystander, but meanwhile you need to perform that and show. But as the situation here, we cannot do that way in online. And practical skills, we didn't do. So what are the preparation of the equipments that is needed, cleaning of hands and wearing glove, positioning the wrist, sterile field, adequate skin preparation that needed to be done, how you will do the cannulation, whether you're doing an ultrasound guided or you're directly entering into the artery and inserting, or you're doing a counter puncture method. So all those things you need to discuss. So it's a practical skill where you will be asked for. But since it's an online discussion, you did communication skill, that's fine. But communication skill wise, it was extremely well. You have done that. And next thing is that how to secure the arterial line, how to connect to the transducer, how to do the zeroing, leveling, all those things you need to discuss. And most important thing, this is what everyone will be waiting for, whether you have disposed of the sharp and all those things
Sharps.
correctly. So disposal is very important. So that is that till the OSCE examiner will be waiting like this, whether you have done that or not. Without doing that, they will not feel that you have done correctly, because that disposal is very important, which again need to be having in our regular practice. So disposing the sharp appropriately, and the gloves, what all be the materials that been used, you have to dispose of. So this is a practical skill scenario, which is difficult to discuss in this way, but whatever easiest one I have given you here, Prince. But just keep in mind you regarding your pie chart. Okay.
Okay, sir. Thanks.
Okay, fine. Thank you, Prince. Now, I'll just have a quick overview of what we are going to offer you on 8th and 9th July 23. So as you know, you are all approaching your exam. So it's basically, we named it as a fast track course. It is a 2-day program that is going to happen in Cochin, Kerala, India. So those who are ready, they can start registering for that. And whatever we have been discussing like this, we'll be doing in the real state. So that's the most important thing, and we'll be giving a real feedback. So those will be the who will be the mentors will be evaluating you, and they will be lay examiners. You will be getting mannequins. How you will get that real exam feel? We are trying to create that by doing a mock OSCE, live OSCE circuit. So a 2-day live circuit program. Who can sit? Anybody who has completed primary and intermediate, who are preparing to appear for the OSCE can appear for that. So this is the proposed plan for this 2 days of program. So from 8:30 we'll start, and course debriefing, how to prepare for trauma station, resuscitation stations, how to do the joint examination, psychiatry station, which is very, very important, because psychiatry station I haven't put in here, because psychiatry station definitely one thing is going to happen. Breaking bad news, teaching station, that will be the day 1. And day 2, it will be completely all about the exam, straight to the exam. So we'll have depending upon the number of candidates, we'll have one in the morning, we'll have one circuit in the morning and one circuit in the evening, with feedback being given for each one of you directly by our mentors. So This is what we have planned. So depending upon number of candidates, the station differ. If we have got 18 candidates, we can have 18 station. We have got only 9 candidates, then we'll have 9 station. Then we'll do it in a multiple circuits. So that's what we have planned it for you guys. So we have one more station, that is station 4, that I can see who is there. Who is there for that? Let me check. Is Rehan here? Rehan?
Yes, I am here.
Yeah. So Rehan, can you, since being already being mentoring various our courses, I don't.
Yes.
Why you have been here, Rehan? You're doing OSCE?
Yes, actually, I have to appear in the June exam, but I was not able to get the visa. So
Okay.
that's why I delayed it to further attempts. That's why.
Sure, Rehan. That's fine. It's very happy to have you. So we are going to a cracker of a station now. Fine.
It's
So-
particularly, it's a bit easier station, I think.
Yeah. So can I get you some difficult station then? I have one more in the loop. So you want an
No
easy or
problem. I
difficult?
can do this as well. I can do this as well. No problem.
Okay, fine. So this is straightforward station. This is just the history examination because, yeah, can you, Mr. Prashant is a 43-year-old male who is presenting with chest pain. He was driving to work when he felt pain in his chest. He stopped the car and decided to come to hospital and is currently pain-free. Take a history and make an appropriate management plan.
Management. Okay.
So I'll give you the pie chart.
And
So again,
Take
history
it
taking is the
easy.
priority and reasoning is very small.
yeah. Okay. So,
You can start.
okay. Hello, my name is Dr. Rehan. I'm an ED registrar. May I know your name and age, please?
I am Prashant. I am 50-year-old.
Okay. Nice to meet you, Prashant. What brings you to the hospital today?
See, I've been traveling. So since last 1 hour back, I had a bad feeling in the chest, and I felt that I'm going to die. So that made me come to the hospital.
Sorry to hear about that. Are you comfortable now, or still you are in pain? So I can ask the nurse to bring some painkillers for you.
Since last 20 minutes, I feel okay. I don't have any pain, but I had this sweating. But after coming to this AC emergency room, I'm comfortable.
Okay. So Prashant, do you want anyone to attend with you, or are you comfortable alone?
Right now, my family is 4 hours drive away from here. So there is no one else that who can come immediately, but I'm okay. You can tell me whatever it is.
Okay, so you told me that you were driving and then you felt the pain in your chest. Can you tell me a bit more details about it? Where is the actual site of this pain?
It was more in the center of the chest, somewhere here.
Okay. And how it started? Was it sudden or it was gradual?
See, I've been driving. I've been since last 2 hours. I've been driving. So I have been having some phone calls in between also. And suddenly, after a phone call, I felt a pretty central chest discomfort.
Okay. So does this pain goes anywhere else in any part of your body, to your arm or your neck, or it is just in the chest?
I just felt it was just there in the chest.
Okay. And do you appreciate anything that increases this pain?
No, I didn't feel that because it was almost there since last. I told you, 20 minutes back only. I have having no pain, but till that time I have having that pain. I just stopped driving and just relaxed, and the pain got relieved.
Okay. And is there any previous episodes of such pain?
No, I don't remember exactly any of those episodes in the past.
Okay. So you told me that you were driving and you felt the pain, and when you stop the car and you take some rest, it relieves. Is that okay?
Yeah.
Okay. Can you rate this pain on a scale from 1 to 10, where 1 is the least pain and 10 is the most severe pain?
Somewhere around 7.
Okay. So are there any associated features like you feel throw up or you feel your heart that is racing?
I see. I felt I was having a profuse sweating, even as there was AC inside my car. But I was sweating a lot, and had a bad feeling that I'm going to die.
So you are having any lightheadedness or any dizziness?
No, no, no.
Okay. Any cough or shortness of breath?
I just felt some little bit of suffocation during that time, but after that, it's fine now.
Okay. And any do you have any fever or do you have any rash on the body?
No, no, no,
Okay. Any weakness of your limbs?
no,
Any neck pain?
no.
Okay. Do you have any past medical history?
Nothing much. I've been got done my all the blood evaluated 6 months back. And the doctor said that I need to come after only after an year.
So do you have any past surgical history?
I got done my appendicectomy when I was young. That's the only surgical history.
Okay. And does any disease runs in your family, like any serious illness, like a stroke or hypertension or diabetes?
My father is a diabetic and a hypertensive.
Okay. Do you smoke?
Yeah, occasionally, weekly, maybe one packet of cigarettes.
Okay. And do you drink alcohol as well?
No,
Sorry to ask this question, but routinely we are asking this question from the patient. Do by chance you use any illicit drugs?
no, 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 never.
Okay. Do you have any allergy to any medication or any food products?
No, no, I don't have.
What do you do to earn your living?
I actually run a family business, so that I am looking after my father.
Are you single or in a stable relationship?
You know, see, my family is 4 hours drive away from there, and we just came from home only. So meanwhile, this happened. We are all together.
Okay. Is there anything that I may have missed in the history and you want me to tell?
Hey, what is happening to me? If you can explain to me, I'll be more than happy.
And apart from this chest pain, are you concerned about any other thing as well?
No, I see this was one of the worst feeling that I've ever had. So I just wanted to be okay, whether I wanted to get it evaluated or that's why I came all the way to the hospital. So nothing has been
Okay.
done to me till now.
Okay. So you told me that you have chest pain and it started 20 minutes back and you were driving that time. And when you stopped the car, you took some rest, it goes away.
Yes. Yeah.
And you are an occasional smoker, but you don't consume any alcohol or any illicit drugs. And your father was a diabetic as well.
Yes. Yes.
Okay. So based on your history, it seems most likely this type of pain, it mostly correlates with a disease in the heart that is called as angina. But it may be a musculoskeletal pain as well. So I would like to examine you and I would
Okay.
like to shift you in an observation area where I will check your vitals. I will do a general physical examination and I will take an examination of your chest and your relevant system like your respiration and your CNS as well.
Okay.
And I would like to take some blood tests which include full blood count to look for infection, urea and electrolytes. And
Okay.
I'll also like to do a heart tracing test which is called ECG and a
Okay.
chest X-ray. And also I will take your cardiac enzymes.
Okay.
So
Okay. So how long I need to be in the
understood?
hospital?
Yeah, it will take at least 2 to 3 hours. You will be in observation. We will give some medicines as well to relieve your pain, and we will do a continuous monitoring of your ECG. And by that time, we will be getting by your results, and then based on there is a score available in our EEG to evaluate such patient that is called a FART score, and
Okay.
based on that, we will decide our further plan. So, have you understood the plan?
Yeah, I'm clear, but I am afraid that it's going to come back again.
No, we will be under continuous monitoring, and we have a team of expert doctors. You will be under our observation area. All the staff will be there, so don't need to have worried about that.
Okay, fine. Okay, fine.
Okay.
Yeah.
Is there anything you want me to repeat, or is there anything you want me to inquire again?
No, no, no. Thank you. Thank you, Dr. Khan.
Thank you very much, Mr. Prashant, for giving the history.
Yeah, thank you. Yeah. It was absolutely pleasure to have you here because we just gave our students that how we should run an OSCE station. So this is
Thank you.
exactly
Thank you for the compliment.
yes, sir. So exactly be the tone by which you were delivering the session, be the way professionally you were asking those questions, reasoning skills, all those things put together is exactly what I wanted. There is nothing more for me to add on here. Whatever you have gone through, you have done a very good introduction. You have offered analgesia. You asked if you want anyone else to be informed regarding the situation, and you went ahead with the classical Socrates or whatever you can call it as OPQRST. When is the onset pattern? All those things you have asked in. Then you went hit the past medical history, any allergic history that you have gone, social history, which is very important, including IV drug abuse, which is again one of the key information that you need to ask in for. Then you always ask that you had any concerns that need to be answered, that you also always to answer that. You go on ahead with the associated symptoms again. So you were trying to get some probable differentials in your mind and plan of action. So that I just prompted you to get some plan of action, but if you're not prompted also, you would have come out of with that. Differential diagnosis, you were just concerned about myocardial infarction and musculoskeletal. That is more than enough. So you have told your differentiate, you have told what is the follow-up plan, answer patient completely whatever is needed, and understanding. Excellent. Nothing more to add. So it's just a clean full score for the station if I was examiner.
Thank you. Thank you. Hopefully, yeah, like I'm planning to give the exam in Hyderabad, so I will attend your live circuit as well that time.
Definitely,
Inshallah.
definitely. We'll meet.
Inshallah. Yes,
We'll-
definitely.
Yeah, good.
Thank you.
So we have any more takers? I've got one station more to you. So let me check my list. We have Dr. Hassan Bilal. Dr. Hassan Bilal is not here. I can call up the next Sneha, Dr. Sneha.
Yeah, I'm here.
Okay, Dr. Sneha, can I know a little bit of your background because I don't have anything in here.
I'm going to take the exam in July.
Okay, coming this next month. Okay.
Yes.
So, okay, so you're practicing emergency medicine?
Yes.
Okay, that's great. So I'll give you the station. It is one day in and day out practice of an emergency physician. So your time starts now. There is a pre-alert about a 60-year-old patient who is being brought to ED in cardiac arrest after a sudden collapse with no preceding symptoms. The patient has received appropriate compressions and ventilation with 3 doses of adrenaline, but it is still without a cardiac output. That is, no ROC has been achieved. No shock has been delivered. He has a past history of diabetes, atrial fibrillation, congestive heart failure, chronic renal failure, and lives at home with his wife. You have a trained nurse and a new doctor with you. The patient will arrive in a minute. So that is the scenario for you. So
So
yeah.
it's a resuscitation station.
Yeah, it's a resuscitation station. So whatever you wanted to do, you verbalize it. That's it. Okay. So you will not be, because being a live OSCE online platform, you can just verbalize that. So this is your pie chart. You have team leadership, a small portion, and a resuscitation skill is the max.
Okay.
So the patient hasn't arrived. So you can plan from the patient arrival or before patient arrival, whatever way which you can discuss.
Okay, I just want to see the chart once. At what time did the patient collapse, and for how long
Okay.
has the resuscitation been given?
There is a pre-alert. The patient has received appropriate compression with ventilation, 3 doses of adrenaline. So that gives you a time frame.
Okay.
So every 3 to 5 minutes, we will do repeat a dose of adrenaline. So from
15
time one,
minutes.
yeah, it's approximately not more than 10 to 15 minutes.
Okay. So you let me know when can I start?
Yeah, you can start.
Okay. Good morning. I'm Dr. Sneha, ED Registrar. May I confirm your name and grade, please?
Patient is in cardiac arrest.
No, it's a pre-alert. So I am doing a pre-alert, debriefing my team before the patient arrival.
Okay, so the debriefing.
Or has the
team is-
patient come?
No, the patient hasn't arrived. So depending upon your questions, I will give you the answers.
Okay, so good morning. I'm Dr. Sneha, ED Registrar. May I confirm your name and grade, please?
See, I'm Dr. Sreekrishnan. I have been working here since last 2 weeks in the ED.
Nice to meet you, Mr. Sreekrishnan. And I would like another staff as well. Okay,
Okay,
thank
there
you.
is another staff joined with you.
Okay. Are you both ALS providers?
Yeah, I've taken ALS. Yes.
Okay. So we are about to receive a patient who's a 60-year-old being brought after a sudden collapse and already have received 3 doses of adrenaline. So we are expecting him he has not yet achieved ROSC. So he's in cardiac arrest since approximately 10 to 15 minutes. And he has history of diabetes and atrial fibrillation. Dr. Sreekrishnan, I'd like you to take control of the airway. So please prepare
Okay,
the
I'll
airway
do that.
trolley. And nurse C, can you please take care of the circulation? I'd like you to prepare the circulation trolley as well as the defib monitor. Thank you. Let's wash our hands, wear PPE, and alert the resuscitation team, adult resuscitation team. Has the patient arrived?
Yes, patient has arrived.
Okay, is there a response from the patient?
There is no
Look,
response.
listen, and feel any signs of life?
No.
Okay, so this patient is in cardiac arrest. Nurse C, can you please start with the chest compressions? And Dr. Shrikant, please, can you be on the head end and start with the back valve mask? 30 compression is to do ventilation. And let's expose the chest and connect the patient to the cardiac monitor and secure 2 wide bore cannula. I should have taken ambulance history as well, sorry.
Yeah, that's okay. That's fine. You're doing good.
Okay.
Just continue. Don't stop.
So let's secure 2 IV cannula and collect blood for hematology, biochemistry, blood gas, blood culture, and also give good quality high chest compression, 30 compressions followed by 2
Monitor is ready.
ventilation. Monitor is ready. Can I please see the monitor? 2 minutes over.
So rhythm in front of you.
Okay, so just hold compression. So it is a sinus rhythm. Is there a pulse?
No pulse.
So please, it's a pulseless electrical activity. Please resume chest compressions. Adrenaline, has it been 5 minutes since the last dose?
No, it's just 2 minutes.
So let's continue with the chest compressions and let's prepare injection adrenaline and keep it ready and wait for my orders. And let's think about the 4 H's and 4 T's. So hypoxia is taken care of. He's already on intubation and bag is ventilating. Hypoxia, hypothermia is ruled out. Temperature is 37. Hypovolemia, what's the blood pressure?
Blood pressure not recordable. He's in cardiac arrest.
Okay. So let's start him on fluids. Since he's a case of atrial fibrillation, let's start on low dose. Let's give 250 for now. And so that he doesn't go into heart failure. It could be his case of diabetes with atrial fibrillation. So it could be another clot, maybe a coronary artery disease, another heart attack. Okay, the blood gases.
Some labs. You have asked
Yes.
for some labs, the EBG has arrived.
So it's showing a pH of 6.93 and sodium potassium is 7.8. So he is having base excess of -19. Bicarb is 13, so he is having mixed acidosis with hyperkalemia. So let's give him injection calcium chloride 10% 10 ml IV over 10 minutes, cardioprotective, and let's start him with 10 units of human activated insulin and 50% dextrose over a period of 20 minutes. Thank you.
Okay.
That will take care of the potassium. And let's also give him a 50 ml of 8.4% soda bicarb, and let me know when the 2 minutes are over. We'll check the monitor
Calcium
for the
chloride 10
rhythm.
ml 10% given. Second dose of fourth dose of epinephrine given, and preparing 50 ml of bicarbonate.
That's great. And how is the after 2 minutes? Let's also check rhythm every 2 minutes and see how is it doing. And let's
The
give
rhythm
him
is the same. The rhythm is the same.
okay. Okay, let's also, since he's a case of atrial fibrillation with diabetes, it could be another heart attack, so clot thrown. So let's give him an injection alteplase 50 mg IV bolus. And if he doesn't respond over a period of 30 minutes, let's repeat another 50 mg of alteplase. Are the 2 minutes over?
2 minutes over.
Okay, can I see the rhythm on the monitor?
Rhythm
And
is the
please
same.
switch roles. Okay,
Roll
this is the
state.
rhythm.
Yes.
Okay, this is the rhythm. Let's check pulse. Is there a pulse?
Yes, there is a palpable pulse.
Okay, fantastic team. We have achieved ROS for the patient. So let's put the patient on the, he's already intubated. So let's connect him to the ventilator machine. I'll do up the setting. Let's start with a target FiO2 of 100% for now, with a tidal volume of 6 ml per kg body weight, idle body weight. And let's give him 1:2 inspiratory expiratory ratio with the RR of 16. Is there a chest rise?
Yeah, there is a chest rise.
Okay, so airway breathing is done. How is the saturation holding?
Saturation is 93%.
93%, fantastic for now. And let's continue to remain like that. Let's target, if he's having another cardiac arrest, a heart attack, then let's target not more than 94% saturation. Moving on to the circulation, how's the blood pressure?
Blood pressure is 70/40.
Okay, so he's having low blood pressure. So let's give him a 250 ml of 0.9% normal saline bolus. And then let's check and auscultate him. If he's not having any features of heart failure, then we can give another bolus and repeat it till we get a palpable good blood pressure.
Okay, fluid bolus given. The previously it's a 250 ml given. Now repeated 250 ml more. Saturation is 90% right now.
90% right now. So he must be, how is the auscultation findings?
Bilateral crepitations.
Bilateral crepitations and heart sounds, any gallop rhythm or S3?
130 heart rate with atrial fibrillation. I couldn't find anything. I couldn't understand because I am a very new
Okay. Okay, so he must be, so it's atrial fibrillation with fast ventricular rhythm, and he's having this thing also. So let's start him with low dose of fluid for now, 50 ml per hour. And for atrial fibrillation, fast rhythm, so he is unstable in that case, since he just returned from a cardiac arrest with having high heart rate. So it's an unstable tachycardia. So we can give him a synchronized cardioversion with a low BP as well. So let's charge the monitor to 100 joules and press the sync button, and let's give a synchronized cardioversion. All clear. Synchronized shock given. Now,
BP,
how is
BP 90/60, heart rate 110 with control ventricular rate.
okay, fantastic then. And BP is also controlled. How about the blood sugar?
Yeah, that's fine.
Let's repeat the blood gas and let me know when it's ready. How
That's
is the
fine,
pupils
Sneha.
bilateral?
That's time. We have been more than 10 minutes. I'm just continuing since how long you will go. So the registration station, it's hardly 8 minutes you will have in the station. So you will not have this long discussion. But I just wanted, since the flow was good, I don't want to stop you. That was the only reason. So you have done fantastically well for a registration station. So one good thing that I know that you have been practicing in emergency medicine, that the way by which you have presented, we come to know. Those who doesn't know, they will not be able to do the station. So that's a key thing that I always say. Whenever you're doing any of these things, you planning for an MRCM, you can do till primary. Intermediate, you need emergency medicine exposure. OSCE don't come without emergency medicine experience for OSCE. If you don't have emergency medicine experience, then it's difficult. So you're done well, Sneha. Thank you. You're
Thank you,
done. I
sir.
have only thing is that you could have thought of this thing multiplies. How frequently you use that? Why you thought of an MI?
No. According to India, it's not, no, it's case of atrial fibrillation. So I thought there must be a clot, and in the RCM guidelines, resuscitation UK resuscitation guidelines, it says
Yeah, it
that
is there, but how frequently you will use that when you have what
we-
another cause? When you have another cause already there, hyperkalemia, and you have got a sine wave pattern, all those things. So
Okay.
maybe you could have waited. I am not denying the fact that you can, as per the guidelines, you can give, but maybe little bit after maybe just 3 or 4, you could have kept that in mind. So that's fine otherwise. Whether
Okay.
we have got a clear cause of a hyperkalemic cardiac arrest with severe metabolic acidosis here. So we could have just pushed some more time by giving a good dose of bicarbonate. We haven't given. I was just preparing bicarbonate. So meanwhile, because bicarbonate, you need some time to give bicarbonate. So that's the only reason. So there is nothing. I'm just discussing.
Okay. The synchronized cardioversion, was it the correct move?
See, that again is a questionable thing, because when you go ahead with the guidelines, synchronized cardioversion is correct. But when you ask me, when you're seeing such patient post cardiac arrest, you have given a lot of adrenaline and you are expecting the heart rate below 150. So that is ridiculous. So you will have increase in heart rate. But only thing at that time, maybe you could have thought of starting an vasopressor agent. Maybe you could have tried with a vasopressor agent if the blood pressure increase. You have given a lot of adrenaline, the heart rate is obviously going to be high only. So that again depends. There is no harm. You have gone ahead with the guidelines. Whatever you said is correct, because it's an irregular heart rate, fast ventricular rate was there, and there was associated hypotension. There is always, you can call it as an unstable. But when you take into my consideration, I would have started a vasopressor at that point of time, because the patient has gone into cardiac failure by giving more fluids, 250 of fluids. You can put that way also. So that's all depends upon the resuscitation team, how they approach it. So see, guidelines are there to have some idea. So sometimes we need to deviate from the guidelines and do things. How frequently you do shock for all the patients who's coming with atrial fibrillation? No, I don't do that.
No.
Yeah, we will give amiodarone and we'll wait. So when we go ahead with the guidelines, there are certain things to be followed, but it's all practice. There is little bit always there is difference. Okay, fine.
I have
Thank
one
you.
question. What is the
Yeah.
dose for the synchronized cardioversion in case of an AF? Is it 70 to 120?
You can go ahead with the higher 120 to 200 joules.
Okay, so AF would be different from the narrow and broad complex.
See, what the problems here that you need to understand is that there are two schools of thought. What we practice in India and UK, there is ACLS, American School of Thought, and European Resuscitation Council. So previously there was a clear-cut American. They were very clear, 50 to 100 to start with. Then you give 100 joules. Then you go ahead with 120 to 200 joules for atrial fibrillation. So now the American guidelines, they are not mentioning anything about the joules. Pediatric, yes, they have given 2 joules to start with, 4 joules per kg. They are given or 0.5 for synchronized cardioversion. They are given. But for the adult pattern, you can maybe being in the cardiac arrest, you can always go ahead with even 200 joules straight away for synchronized cardioversion.
Okay.
Okay.
Thank you.
Okay, fine. Thank you. So we have concluded our session. So any more questions, we will be happy to answer you. So thank you from the StudyMEDIC team. So we have a couple of chat. What's the chat box? Okay. How much time needed for the preparation of OSCE? Kindly guide. So again, the guide, it depends upon how you are, whether you are practicing or whether you are just waiting for preparing for OSCE. So if you ask me, if you're a practicing physician, 3 to 6 months will be an ideal time. Or you're just sitting for preparation of OSCE, do some good online programs, do some live circuit programs. So 3 months may be sufficient, depending upon your experience, because you are thorough in your clinical examination, all those things, history taking, then it's just a quick review of all those things. is there any passing ratio of Asian candidate if candidate make an attempt in London Center or in other? See, this as per the outcome guidelines, there is nothing like this. They haven't put anywhere. But what general feedback that I have got is that their station and their thought process when you give exam in London is little bit different. So the stations that they give you, what they expect really, when you're practicing in London, it will be easy for you to take the OSCE there. But for an Asian candidate, it might be little bit difficult to take the exam in London. So I always tell the Asian candidates to take it in the Asian countries. So preferably not in London. So there are colleagues who have completed practice in India and gone to London and cleared the exam in London. But there is always a slight risk because the station scenarios might be different. Psychiatry stations might be, their actors are too good. They are all trained actors. So they are the same actors for the FRCAM also. So the actors are too good. So that might be some difficulty in passing London. But if you are getting a center in Asia, that is well and good. I hope it was effective and useful for you. So thank you for all for the patient listening. So can we close? Anyone from StudyMEDIC? If you have anything else to add on, otherwise I'll close the session. Okay.
No, sir. Thank you.
Okay. Okay. Thank you. Thank you. Bye. Okay. Thank you all. All the best.
Excuse me? Still there?
No, sir. Sessions are done.
Just I want to
Keeping
ask how many sessions per week? Yani? How many time per week? 2 times, 3 times per week? Do you
It
have
is
any
actually
talking
idea?
about paid one or free one?
we have started.
Hmm?
We'll share it with you, Mohammed Ramdan.
Say again?
We'll share it with you.
Okay, thank you.
Yeah.